So I now even the you have a slides to project for everyone's CV. Hello.
Hello. Yes, sir.
Ma'am, you have got a CVs of everyone?
No, sir, I didn't got it.
Huh?
No, sir, I don't have it.
That introducing slide.
So introductory slides will be played by you only, na?
Hello.
सौरभ जी आपने क्या पूरा होमवर्क नहीं किया है?
किया सर मैडम वो वाला स्लाइड जो आपने हमको भेजा था ना वाला स्लाइड को प्लीज
मैम वी आर लाइव सर, वी आर लाइव सर।
अरे लाइव डालने से सामान पूरा नहीं लाइव कर जा रहे हो यार, एक मिनट रुको।
Good evening everyone. This is a program which is going to discuss about targeted Omalizumab anti-IgE therapy. Its utility in various clinical fields besides the respiratory medicine. We have a respiratory medicine specialist, Dr. Arun and Dr. Aditya Chawla, and then we have a dermatologist, Dr. Vinay Singh and Dr. Pooja Agarwal. So we know that Omalizumab has been introduced to India in 2008, and since then it's been almost like 15 years we have been using Omalizumab. So our experience of using Omalizumab is the largest with any biologic in the history of asthma and allergies. But we know that this molecule is targeting IgE and hence not restricted to lungs, but also to other IgE-driven diseases which are in the skin, where in the nose, where the sinuses, and these are also very important comorbidities with asthma which trouble us in the treatment. So I think today's seminar is going to be of great help in coordinating the skin and the lung manifestations of IgE-mediated allergy and how to tackle it when our routine treatments fail. And we look for targeted therapy, which is anti-IgE therapy. Dr. Arun, so can we start with you or can we start with Dr. Vinay? So what should we do?
I'll start, sir.
Who's ready?
I'll start, sir.
Right. So Arun is, Arun, would you introduce yourself?
Sir, I'm Dr. Arun Kotaru. I'm practicing at Artemis Hospitals, Gurugram.
So excellent pulmonologist from Artemis Hospital is going to present case and let's discuss his case. So over to you, Arun.
Thank you, sir. Thank you. Sir, as we all know, Omalizumab is indicated for moderate to severe asthma where the conventional medication is already not working and patient is requiring multiple doses of oral steroids or having repeated exacerbations with perennial allergy, positivity like dust mite, cockroach, or a common pollen allergens. So I'm going to present an atypical case where initially there was management being carried out tangentially opposite side, and patient had a typical presentation where we found out ultimately that he's having asthma, which is into all these scenarios. So without wasting any time, my case is a 17-year-old male. His height is 176 centimeters and weight is 63 kilograms. He had no comorbidities, presented with sudden onset chest pain and associated with breathlessness. There is no history of trauma, there is no history of any routine gymming or any severe activity associated with the pain. So with this presentation, the patient presented to a local hospital where there was an X-ray done, where they said that he's having a pneumothorax, and he was referred to our center. So the patient was initially examined by the other pulmonologist in the same hospital. So there was decreased air entry on the right side, chest X-ray showed right pneumothorax, and they immediately did a CT scan because for a 17-year-old, the first common thing which we suspect is a Marfan's. So they did a CT scan rightly. The CT scan showed a large pneumothorax, along with, you can see on the right extreme corner, you can see subpleural blebs, which are the most common reason with the rupture and they lead to pneumothorax. So this patient was immediately admitted and an ICD was placed on the same day in the ER. And post X-ray, the lung was completely expanded. There was no leak in the ICD. And since there was apical pleural blebs, patient was given an option of pleurodesis, and father being very concerned about a 17-year-old boy, he said, if it is going to happen again, please do the needful step. So pleurodesis was done with talc and negative suction was attached for 48 hours, and there was a clamping which was done, and repeat chest X-ray was grossly normal, and the ICD was removed on 27th of February and discharged on the next day. Now again the patient presented on 6th of March with again the same symptoms. Again, the repeat X-ray, which you can see in the right bottom, it is again showing the right-sided pneumothorax after a talc pleurodesis. Obviously, we all know that pleurodesis with talc has a success rate of 68 to 70%. So most likely another bleb which must have ruptured. So the patient was readmitted again and ICD was inserted again. Now the father was apparently not so happy because it was a repeat. The initial process of doing a pleurodesis was that patient was will have a repeat episode. In spite of doing that, there is a repeat episode. So without any delay, he wanted a thoracic surgeon opinion. Thoracic surgeon immediately, as you know, once he comes into the picture, he says that there is a bleb, multiple blebs in place. So there is a issue of failed pleurodesis. So patient was given an option of wax wedge resection and the removal of all the blebs. So multiple bullets which were present in the apical lobe of the right lobe was removed. And as mentioned in the surgeon note, apical lobe was tightly adhered to the chest wall cavity at the apex. So you can see the post-op X-ray, immediate post-op X-ray, as well as the X-ray which was on the day of discharge. So patient was discharged with one ICD in situ, and patient was called back after 7 days, and the rest of the ICD has been removed. Now again, patient presented to our OPD, which is Dr. Rajput's OPD. So patient presented to OPD on 24th of March with same symptoms, but only thing is he's wheezing this time. So X-ray, as we all know, there is hyperinflated lung fields, but there is some amount of air which is residual left in the apical cavity. Sorry for the image quality. Now we started probing the patient. Is it the first time you are having these symptoms? So he said that I used to have nasal blockage, I used to have mouth breathing. And once we probed the mother, because every time the father is accompanying the child, this time the mother was so concerned that what is happening with my child, he underwent surgery, in spite of that he's having problem. So we probed that mother. Mother said that every winter, every change of season, he's used to have problem. And he often misses school because of headaches. And on further probing, he said, the mother said that her mother had similar history. She used to be on inhalers for a while, but she used to be very mild. She used to be a mild variety. So the child, when he was around 9 years, there were 2 ENT consults which were taken, apparently for adenoids, but there was no documentation available. So with this history, so we went ahead with the PFT, where there was an obstructive curve and there is significant reversibility, though we would have appreciated a more reversibility in a 17-year-old, but it is enough reversibility to categorize the patient as asthma. And we went further ahead with phenotyping, where serum IgE was done, which was around 1300, and absolute eosinophil count was 340, and eosinophils were 3%. Now the patient it was very difficult for us to convince the patient. So immediately we told that it was this long height which was relating to these problems, which was by the other unit. Now suddenly we are changing the diagnosis and saying that it is asthma which led to everything. So once we started the patient, Dr. Rajput was very meticulous in convincing the attendants, saying that it was the asthma only which led to all these things. We showed them different case reports across, which I will be showing eventually. Now the patient was convinced and he was ready to take the inhaler. So we placed him on the most formoterol budesonide 320 because he doesn't want the inhaler to look like an inhaler because of his social stigma in the school. So we gave him 2 puffs initially, followed by Motilicus levetiracetam combination and nasal spray for his nasal blocks. So initially he was much better. He came back, he said that I was doing much better. There was no symptoms. He has no breathlessness. He is able to climb the stairs. He was doing well. But in the month of May, he had again proper wheezing with fever. So a short course of prednisolone was given for 10 milligrams of prednisolone was given for 5 days in April and May. After that, he was fairly okay. But again, he came back in June, where he said that he was not feeling well. And with the amount of history we had in the earlier part, we gave the option of giving Omalizumab because it is an atopic variety and the patient was not doing fairly well with significant dose of ICS as well. And he required 2 oral corticosteroid doses as well. So as per the dosing, because in children, as per the criteria, we can give IgE till 1300. He is above that criteria. So the ideal dosing should be 450 milligram every fortnight. But because of the cost factor and initial response to therapy, we opted for 150 milligram every fortnight for initial 4 months. So once he showed significant response, because cost is a huge factor in this thing, and earlier the Omalizumab was slightly priced higher than the existing price. So we shift, once there is an enough response, we shifted him to 150 milligram every month. So after giving for 14 months, the patient was very well. He was doing very well. He was not missing his classes. So we stopped the medicine. He was fairly okay for 6 months. Again, in the month of March this year, in the month of December 2022, he had an exacerbation. So we gave him a steroid course for 5 days, and we started him back on Omalizumab again. The second dose he took last month, which is January. Till date, he took a total of 31 doses. And follow-up was done once monthly. He was very meticulous with his follow-up. Maintenance ICS lab was followed. Patient significantly improved, and there was no clinical worsening or no repeat pneumothorax which happened again. So if you go to the literature, particularly in adolescent age groups, it is not very uncommon to see patients presenting with pneumothorax when they're having severe asthma. So if you see around all the data available in the literature, most of these age groups, they belong to 10 to 19 age group where they were presented with pneumothorax or pneumomedicinum. This was taken from a review article where they described all the cases, what was the underlying history. All the patients presented with similar symptoms, but the underlying history was asthma. So few people needed needle thoracostomy where the size of the pneumothorax was very small, mostly from data from the UK. And few people required ICD followed by pleurodesis, depending upon the recurrence of pneumothorax. So to discuss, it is a known fact that asthma predisposes susceptibility to pleural blood rupture leading to pneumothorax and pneumomedicinum. Eventually, there are many cases in the literature where there was no pneumothorax initially. There was a pneumomedicinum initially and leading to pneumothorax later. Most of these cases, they had tension pneumothorax because initially the pneumomedicinum is missed on the X-ray. The recent literature where they analyzed around 87 pediatric patients, they found out that there is a secondary pneumomedicinum which is predisposing factor for most of these asthma cases where they led to pneumomedicinum. So particularly in this case, the challenge was again to re-diagnose the patient, to convince the family, to convince the patient to start on inhaler as well as on biologicals. Now the remaining challenges which left is, the only question the father asked me is how long, how many times you want to give, what is the dosage, how long you want to give, and what are is there any complications. Now as said by Dr. Talwa sir, because we have been using for the last 15 months, the initial misconceptions about development of malignancies, strokes, all these things have been potentially ruled out. The only thing which has been still persisting is the anaphylaxis. After giving multiple doses to any particular patient, we are sure that he is not going to develop any anaphylaxis now. But the other treatment is development of autoantibodies, which only literature will tell us. With this, I conclude my case. Thank you so much.
Thank you, Arun. Thanks a lot for bringing out this wonderful case. So I can see certain highlights on this. And Aditya, can you manage your camera now? No, I think, yeah, I can see you. Yeah. So Aditya and Arun, both being pulmonologists, will be, very amused to see this kind of unique case where severe asthma presented for the first time with a pneumothorax, and the pneumothorax was treated surgically, and everything happened, and the patient was discovered to be having asthma later on. And very convincingly, Arun showed us number of, the case reports as well as the series, which show that in young children, it's possible where the asthma goes undetected and becomes severe to the extent that because of the hyperinflated lungs, the lung ruptures, and then it requires a treatment for the pneumothorax. But uncontrolled asthma is something which this patient had. And ultimately, despite ICS LAVA, when he was not improving, he was also given oral corticosteroid bursts and finally put on Omalizumab. And the first attempt to take the patient off the Omalizumab didn't succeed. So obviously, it had to be restarted. So I think this has brought on all the most important points in using Omalizumab therapy. Number one point is that when you give it, the dose is related to IgE level as well as the body weight of the patient, and that might dictate a higher levels of anti-IgE drugs to be given to these patients, which ultimately will pinch the patient's pocket to such an extent that they may not be able to afford it. And it's not a question of 1 month or 2 months. It's going to be a minimum of 1 year. So Omalizumab is one drug which gives its true, the response or the responder rate at 1 year. So that is one of the things which is like little later, where you need to wait for a little longer. And their case clearly demonstrates that patient was a responder to Omalizumab. So Arun, what only one or two questions before we move on to the second case. I know that you have brought it how long. As far as the safety part is concerned, so a quick comment is that we have a study of 15 years of Omalizumab on record, where 8 patients were followed up, and there was no adverse events or any safety signal raised in that. So large studies are up to 9 years, but the longest study is up to 15 years. So there is a safety data which is available for that. Potentially, you talked about developing antibodies to anti-IgE. So that's always a possibility, which our rheumatologist friends are struggling at the moment. But by and large, these kind of antibodies are to the level of less than 5%, which is not clinically effective to reduce the drug efficacy on a long-term use of Omalizumab. But I think one more point was that many a times we have to underdose the Omalizumab because of the cost factor. And there's no data to tell that underdosed Omalizumab also works, but it does work in the clinical scenarios which we see in our daily practice. And your case actually illustrates it very nicely that you can still use it so long as you have a conviction that it works. And secondly, that you have a time frame where you are looking forward to that it will show its response. So Arun, then the patient was doing so well on Omalizumab. So did you consider, stopping it altogether, or you wanted to phase it out? What was in the mind, or was it the family which wanted that, okay, we have done enough, patient is doing well, let's take off and see what happens?
Sir, it was a conscious decision that because it is ultimately he has spent around 7 lakhs for his surgery. So ultimately the father is apprehensive that how long I can continue with a 17-year-old child. So we made a conscious decision to withdraw the drug. But eventually he did well for 6 to 7 months, but ultimately he'll end up with an exacerbation. Yeah. So we start with no other option.
So the export study itself shows that even after 5 years of Omalizumab, in the group of people whom you continue, they show a reduction in exacerbations by 60%, while 48% of those patients who discontinue will have another exacerbation. So obviously, continuation is something which is desired, but of course not always possible because of the cost factor and other things we do understand. Did any other biological came to your mind while you were selecting second time after 6 months to consider any other biologic, or just to continue with the same biologics?
Sir, we obviously thought about the other one, but it is still expensive, more expensive. So the father was right away said that it already worked, please go with the same molecule.
I think the basic crux is that it has already shown that it worked. So there was no point in switching the biologics. The data of switching the biologics also show that almost 80% of patients who are given Omalizumab, they continue beyond 1 year on Omalizumab, and 20% those who are switching to the other biologics, which are anti-IL-5s, and till the last 4 or 5 years. That is primarily because of the insufficient response or inadequate response. And inadequate response is in the form of reduction in exacerbation rates and oral corticosteroid maintenance dose to less than desired, as we expect from the biologicals when we use them in such cases. So I think an excellent case with lots of pointers, lots of interesting things, and we'll move on to next is, I think we'll take Vinay, your cases for a dermatology, and then come to respiratory again.
Yeah, sure, sir. I would like to share. Do you have my cases, or should I share?
You share, I think. Please give
Okay.
them a command to share the screen. We have a lot to learn from you people. Actually, dermatology is one of the very important aspect of an anti-IgE therapy, but very little known to us. So I am very excited to learn.
Yes, sir. And if I may ask Dr. Arun, what was the IgE level after 6 months of initial therapy with Omalizumab?
Sir, we don't do the repeat testing of IgE. Right from FMC, we have been following
it
this
should
protocol.
not be done.
That's
Yeah.
very good, Arun. I think you brought a very good point that there is
Yes.
no point in doing a repeat IgE levels. The response is clinical, never in the total IgE.
Yes.
Because total
I
IgE
brought it this.
very nicely,
brought,
Vinay, you brought this. I think derma practice doesn't need it, but chest people keep doing IgE levels. They are very happy with the IgE levels. But what we forget is it is total IgE, which not only gives IgE, but gives anti-IgE also. So the level
anti-IgE, yes. That is why, because initially when you give Omalizumab, then the Ig levels you repeat after 2 months, you find it has increased. It is just because what you said, Dr. Deepak, very rightly. So we don't do repeat Ig levels and we go for the clinical response.
Right.
So, and in past 2.5 decades, I have used so many biologics. One of them is Omalizumab. I started using in 2009, late 2009, early 2010. And I have used quite a good number of patients on Omalizumab earlier. And now also I'm using quite a few. So I'll talk about 2 cases because the history is very typical. This is a case of a young woman who was about to get married. She reported to my OPD with chronic urticaria of 3 years, chronic itching. She reported that she used to get redness and swelling on neck, shoulders, lips, recurrent for last 3 years. She used to take some antihistaminics, steroids, Avel injections, Efcorlin, and all sorts of steroid treatments, and she used to get better for some time, and then she used to get it again. I went for some tests, and in that I asked her to go for IgE. It was raised beyond 3000. The lab reported more than 3000. Leukocytosis was there. ANA was negative. Although she reported that she used to have pain in the just behind the eyes. So I asked for ANA. It was negative. She was not having any rheumatological problem, and on or her parents' insistence, I asked her to go for comprehensive allergy panel test, where rajma, cheese, and tomatoes were the culprits, which were highlighted very high. I told them that this is not a very absolute test, but of course you want to go for it, go for it. And surprisingly, she used to eat rajma and cheese whenever she used to frequent out with her in-laws, would-be in-laws, for some shopping, and then she used to get, the very next day she used to get all this. So I started her on Omalizumab. This is a 5-year-old case, and now she's better. We continued for 5 months and she was absolutely fine. After that, she never used to have the same urticaria kind of a thing, and now she comes for other things, for acne, etc., for her child also, but she is absolutely fine. So Omalizumab was the savior for her, because she was receiving various steroid and antihistamine treatments, and now she is perfectly doing fine. This is one case where this is a thing, rajma, cheese, and tomatoes, which she used to love, and this all started giving her problem.
So Vinay, are we going to discuss this case or both the cases together?
Yes. So I am the case is open for discussion. Anything you want to know?
This is a wonderful case. You have brought a food allergy as well as a chronic idiopathic urticaria. Both are the indications for Omalizumab.
Yeah.
But food allergy is something, because most of the West data is on a peanut allergy, but our report here shows rajma and cheese and tomatoes. So maybe it is the rajma is the predominant one, because we would consider that protein as one of the important one. Dr. Arun and Dr. Aditya, would you give any importance to the comprehensive allergy panel when you see in asthma, particularly in the patients with the asthma?
Sir, actually, the patients coming with food allergies are also very predominant also. And we can give importance, and we can stop those things to the patient is using, and we can tell them to avoid those things and see the response of the treatment after that.
So invariably, asthmatics do have a lot of things related to food, which they find that they are allergic to. And some of the times, actually, you can have this kind of a clear-cut correlation, as Vinay brought it, that whenever she goes out with her in-laws, she takes rajma and then she comes cheese and then come back home with the severe urticaria with such a direct kind of a connection. In
Yeah.
asthma, that is little difficult because many times there are compounding factors, but there are certain patients who can vouch for it, that there are number 1, 2, 3 things which are there. But by and large, these comprehensive allergy panels are very confusing to us
It is very
because
confusing.
they
Yes.
come up with the kind of reports to which the patient has never been exposed at all, and still they are so strongly allergic to it.
Yeah.
But then anyways, I
Positive
think
to
there are
beef.
Yeah.
Some patients come out to be positive to beef also.
some
Yeah,
patients.
yeah.
I think
So
clinical
many.
correlation is the most
It
important
is
thing
most
for
important.
respiratory allergies. But
Hmm.
this is a skin allergy, and we know that the food allergy and the skin allergy do have a direct correlation, which Vinay could demonstrate here. So Vinay, I think two things are very important here. For a food allergy, you used it for a chronic urticaria, or it was not an idiopathic urticaria, it was a food allergy causing urticaria.
Sir, I think it was chronic idiopathic urticaria, but idiopathy is now related with food.
Okay.
Where we call chronic idiopathic urticaria, where we cannot find the culprit, where we cannot find the antigen which is causing it. But here, probably I'm using the word probably, because once she stopped taking these 3 items, and she received omalizumab because she was wary of taking steroids and antihistamines.
Okay.
Nowadays, patients are very, they have a tool in their hand and they just Google it. So she said, no, I am getting married. I don't want any more steroids. So do we have something else? I said, yes, it is there. And it was pretty expensive at that time. As Dr. Arun very rightly said, at that time it was quite expensive. But she took it and she is fine now.
Right.
And one important
Last
thing is
comment,
all
I
these
think-
biologics, wherever they are being prescribed, it is written that moderate to severe. Always, in all diseases, we should always understand that moderate to severe, it's a bridge between a moderate disease and a severe disease.
Sir, even the literature says moderate cases respond better than severe cases.
Yeah. But their product insert, or even whatever studies are there in past 3 decades, they all say moderate to severe. Head-to-head
So
trials
this-
also.
all the trials included moderate to severe, so that's
Yes,
why it
yes.
is moderate to severe.
Moderate to
Rest of
severe
the-
only.
and that time there was no terminologies which were very clear about severe and moderate. So I
Yes,
think
yes.
all the studies which are after 2016, 2017 have got more clear criteria.
More clear
And
idea.
anti-IgE, most of the studies way back into before, in fact, 2010 itself. 2002 was the time when omalizumab was actually got approvals for the use. So that's long ago, actually, long story.
Yeah,
I'm
yeah.
very happy. I will ask more questions because time is very less. But the protocol used to be 150 milligrams every month for 6 months. That's what I used to follow. So that's not related to the IgE level for urticaria. Is that right?
No, sir. It is not related, but we don't go for IgE, repeat IgE, whether it is 3000 or 200 or whatever it is. It depends on the patient's profile.
So my question was more related to actually the dose is how much is the dose?
Sir, we give 300. We give 300.
Okay,
Yes.
300.
For urticarias, we give 300.
Right. 300
Urticaria,
milligrams once
angioedemas
a
also
month.
we give 300.
And
So,
generally you give it for about 6 months, right?
So it depends on the response of the patient and, of course, pocket of the patient. Now it is
How
quite
long they can afford it.
yeah, how long they can afford it and
Okay.
how long they feel good. I
Right.
treat angstpond also. I treat psoriasis, psoriatic arthritis. So same applies to every patient.
Okay, so we can move on to your case number 2.
Yes, sir. This is a case number 2. This patient is having so many comorbidities, ranging from diabetes to blood pressure, cardiovascular event has happened, and he has received steroids for some reason earlier, because there was some kind of problem with his, as he told me, there was some, he did not have any papers with him, but some problem was there with his pelvis. So avascular necrosis happened because of taking steroids. So this is a typical case of polypharmacy, and he complained of burning, itching sensation, redness on the neck and trunk only for 2 years. And this was so severe that he used to call me late in the night, 11 p.m. Doc, kya karu main? I have taken Atrax. Ab main kya karu? So, and he was again given steroids also from various our colleagues, but he was not satisfied. His IgE was very much raised. So, and he insisted that please go for some more test. So I asked him to go for histopathology and drug allergy test, because he said, I am on so many drugs. In a day, I take around 30-40 drugs. So please go for some test. A drug allergy test was done. He was found sensitive to beta blockers. And in histopathology, spongiodic dermatitis was found. This means that probably there is a drug allergy which is leading to his burning and itching sensation on the neck for so long. I had a conversation with this cardiologist. His beta blockers were changed to some other modality of treatment, and he has received 5 doses of 300 milligrams of Omalizumab so far, and he is perfectly fine now. He is doing last week only I gave him 5th dose, so he's doing good.
Okay.
So this
I
case
think-
I brought is just to highlight the drug sensitivity in urtic areas, which
So it
can
will be
lead to
basically a drug-related allergic dermatitis. Is that right? That's
yes,
what
sir.
it-
Yes, sir.
Okay. So I think this is another field where Omalizumab has been tried, and again very nicely brought out the case where there was a sensitivity to beta blockers. And your avascular necrosis reminds us of our asthma patients who keeps getting steroids and develop avascular necrosis. And then you start thinking that you can't give steroids anymore, and you have to go for biological options.
Yes, sir.
I think this is also an excellent case which you have brought that. And these are actually the on-label indications, basically. So you can use them. Only thing is that you should know that.
Yeah.
So thank you very much, Vinay. I'll move on
Thank you,
to
sir.
Aditya.
Thank you, sir.
take your case.
Yes, sir.
So Aditya has a long list of degrees, qualifications, fellowships. He's a consultant at Jaipur Golden Hospital. He's a fellow of critical care medicine, and a number of other things, which I think because of the time, I think I please allow me, Aditya, to immediately get over your case, right?
Sir, बच्चा हूँ आपका. Sir, I'm going to start with my case.
Yeah.
Mrs. N, a 31-year-old woman, she's a housewife. She presented with cough with expectoration and shortness of breath since 3 months, which was increased since 15 days. But the symptoms have been persistent off and on since last 5 years. Patient is having a history of asthma with her grandmother, family history, and she also has a history of recurrent nose blockage with the change of temperature, and in the rainy season from July to August, and in the winter season from November to February since childhood. No smoke exposure was recorded, and increase in the symptoms on exposure to dust and smoke and perfumes and kitchen fumes were noted. She has recurrent sneeze, and she also has wheeze on auscultation, and she also has a history of acid reflux. Her ACT score was 19, which indicates that her asthma is not well controlled. On physical examination, the condition was stable, and she had bilateral wheeze on auscultation. Lab findings were more or less non-significant, except on the differential cell count, eosinophils were 8%, and she was on she is on medication with nebulization with formoterol, budesonide twice a day, MDI tiotropium 2 puffs once a day. Her inhaler technique was checked; it was satisfactory. Fluticasone propionate nasal spray is also being used, and she was taking doxycycline once daily, montelukast once daily, and pantoprazole for reflux once daily. So her X-ray more or less shows to be normal. Her PNS X-ray view was done, and her PFTs were also done. So this reported to be severe obstruction. And the graph also, she was not able to make the complete graph. And she was also subjected to allergy test, a skin prick test, which was positive for HTM and insects, Acarius cyro 2 positive, dermatophagoids, farine 3 positive, cockroach 2 positive, mosquito 2 positive, and moth 3 plus. Biomarkers, her IgE level was 1063 and AEC level was 260. Others, FeNO was normal, and IUS, she showed increased central and peripheral airway resistance and with post-bronchodilator improvement. So now the case is up for discussion, sir. Now the patient is up for starting the treatment of Omalizumab or any biologics, because she has been taking steroids and Montelukast off and on since last 5 years, sir. Sir, you are on mute, sir.
Great, Aditya. You have brought again a typical case of severe asthma who's on whole loads of medication. Patient is
Correct.
still having so much of respiratory morbidity, so much of poor lung functions, and all other markers of severe asthma being there. So very appropriate candidate for a biological. So tell me, how did you choose and which biological did you choose?
Sir, I chose for Omalizumab. Patient is put on Omalizumab. She has been taking the dose since around 4 doses she has took on 15 days gap she is taking, and her weight was around 62, 64 kgs. So she was put on 300 milligram initially, and she is doing well. She is showing response, and but I want to continue her with Omalizumab for 16 weeks. Then only we want to check if on stopping the symptoms don't persist.
Excellent point, Aditya. You have brought that in all the clinical trials of Omalizumab, the first assessments to look for whether the drug is effective or not is at 16 weeks, as you said. And sometimes we go up to 24 weeks, depending upon whether the patient is doing better, may not be the best, because we know that Omalizumab keeps on improving its performance over a period of time. So even after 1 year, you will realize the second year may be better than the first year for them. And then third year may be better than even the second year. So long-term use definitely comes in. But you are right that the cost factor, the other things do
Correct.
come in sometimes. But thankfully, we have biosimilars today. We are using biosimilars. So that will be my last question about biosimilars. But right now, I think in this case, what would you expect from this patient at 16 weeks? What are your expectations to discuss on the table with the patient that, look, you are doing good with Omalizumab, we need to continue it. And if we discontinue, we are going to go back into what you were before. So how do you carry on with that?
So I am expecting, sir, improvement in the lung functions, and the patient experiences less number of exacerbations per week or per month if she is talking to, because her ACT score was 19. This ACT score is according to 4 weeks of the condition which is recorded. So I would like to ask her for every month that how many exacerbations she is facing and the lung function is improving or not after 16 weeks.
Great. I think this all points have been brought very well by you, Aditya, that 16 weeks you are going to look for a reduction in exacerbations as well as improvement in lung function. So there is one thing that, all these biologics in various studies in the clinical studies did show that the FEV1 improved only about 100 ml to 200 ml. However, the real world studies did show dramatic improvements in FEV1, and that's happened in Indian study because we did this EASE study, which was done in way back 2009, 2010, 2011, which was subsequently published also, and it showed that FEV1 improved up to 300 to 400 ml in some of the patients. And that was very surprising for our international colleagues, because they never reported that kind of an FEV1 report improvements. But now when I was looking at the data of 2018, 20, and real world data, we were finding from Brazil, from all other, African countries, as well as in some of the European countries, they are also pouring in with the data that lung functions do improve with Omalizumab. So it's not only the exacerbations and the oral corticosteroid maintenance dose we are looking at, but also to improve the quality of life, asthma control, multiple points which we look at it. So any limitation point, Aditya, for you to use Omalizumab in your mind?
Sir, only the cost right now in our Indian scenario. Rest, everything is good for the patient, sir.
So cost, according to me, is about 10,000. There were days when we used to spend almost 35,000 rupees for per vial. So considering that, I think the cost is still less, but it is still very high.
Very high.
And it is real very, very high and steep at the moment even. And with the biosimilars, actually, we expected it to be a little more cheaper, but it's not. So Aditya, how long you plan to give this patient if she's doing well? 1 year, 2 years, 3 years, 4 years, 5 years?
Sir, at least 1 year, sir.
And as long as the patient's pocket will allow.
As long as the patient's pockets allow, right, sir?
Most of us finally will make a compromise.
Sir, actually, I would like to comment, sir. I have a patient who is of the government panel. He has been on Omalizumab since last 3 years. मेरे पास उसका detail नहीं था, sir. So I could not show all the PFTs and those because recently he has not come in last 2-3 months. but he's regular in touch on phone, and he has been maintaining his level of the FEV1 on around 54-55%. When he reported to me, he was on 22%, sir.
So it's dramatic improvement over a period
Correct,
of time.
but he's
So
taking
that's-
Omalizumab since 3 years, sir.
Right. I think that's a very good thing. And I think you have again hit the nail very correctly. You know, if I look at the largest, a patient who would have taken for the longest time Omalizumab, it will be somewhere around 7 years going on. But that is also a panel patient who is getting free Omalizumab, and they
Correct,
don't
sir.
have to pay from
And
the pocket.
he was taking Xolair, sir.
So obviously these are the people who were initially on Xolair and they are not paying for it. So still they know the cost of the medication, that how expensive it is, and they value that one. And the longest the self-paying patient I could record is only about 3.5 to 4 years. That's the maximum patient could afford. But anyways, that is still a point. But did you find any difference between Xolair and a biosimilar which we are using these days?
Sir, there is a difference, sir. In the control, in the asthma control, in the lung functions don't improve that dramatically, which was improving on Xolair, sir.
Okay. So I didn't find any palpable difference, but maybe it's like I have also not looked very deeply into it. So maybe I'm not very well aware about that point, but that's one of the points which is very importantly raised. And I think we can quickly move on to Dr. Pooja now with her cases. So Pooja, will you be on board now with the next case? So you need to get your case on the screen. So please allow her to share the screen. Admin, please allow her to share the screen. Aditya,
Okay, sir.
you stop for sharing screen, Aditya, so that she can actually start.
Done, sir.
Yeah.
Yeah, hi. Good evening, everyone. It's pretty late now already. I'll just quickly take my case. So mine is a very straightforward case. So she's a 46-year-old female who presented with wheals in generalized distribution since more than 10 years. So chronic history 1. She had angioedema, that is, the episodes were associated with swelling of the lip, breathing difficulty in deglutition on several occasions. There were no inducible factors. She required multiple emergency visits for injection because of the severity of the episodes. She was severely distressed and it affected her quality of life. She was first seen by us in 2015, then she was lost to follow-up. And then again, since 2022, mid-2022, she's with us again. So in the past, she has received all kinds of antihistaminic, the second generation H1 blockers, desloratadine, levocetirizine, hydroxyzine, fexofenadine in various doses and combinations. She has also received H2 blocker ranitidine. Then montelukast was also given to her. She has received various courses of steroids in form of prednisolone, betamethasone, and deflazacort. Also, she was given about a 3-month course of cyclophosphamide. So at any point of time, she was taking up to 5 antihistaminics a day, and that too with partial response. Comorbidities, she was hypertensive and she's currently on telmisartan. She developed menorrhagia and diagnosed as leiomyoma with adenomyosis in 2021, and for which she was hysterectomy was done. She again in 2021 she was diagnosed as diabetic type 2 and dyslipidemia, for which she's been started on metformin and atorvastatin. So routine investigations have mostly come out to be normal. Her IgE was done in 2015, which was not very high, 168, and in 2021, it was 229. So she has been admitted thrice with us. So it's a joint, she's been admitted with the physician from emergency, and we managed her in the as a referral physician. C3, C4 were normal. Comprehensive allergy profile was done, which was negative for all kinds of allergens. So as a routine practice, we do not recommend comprehensive allergy profile for the lack of specificity, but a lot of time patients do want to get it done, and that's why it is being done. Thyroid profile was normal, antithyroglobulin antibodies were also normal. So because of the severity of the episodes and the number of hospital admissions that she was requiring, and she was on steroids. So when she came to me, so we decided to start her on Omalizumab. So again, in urticaria, the dose of Omalizumab is irrespective of the weight and IgE levels. So it's the standard dose of 300 milligrams subcutaneous given monthly. So she received a first injection in June 2022. And again, she was lost to follow-up for a while and again landed up in emergency in November. And then in November, she was admitted again, and we gave her a second dose of Omalizumab. Now, after counseling, now she has understood that she needs to take Omalizumab regularly. And since then, she's taken a third dose in December and then in Jan, and she has no admissions and no severe episodes. And currently she's on Allegra 180 milligram once a day. So that's my case.
Excellent, Pooja. You have brought the same case, urticaria, which is troubling them day and night, and it is itchy everywhere. And all these Allegra and Atrax, like Vinay also brought that case, it doesn't work and they keep troubling the patient. And Omalizumab really works. I only have a small comment to make that now, of course, our dermatologist friends are very enthusiastic and using it. But previously, when I was the one who was giving it for urticaria, what we used to find it's, that after the 6 months course is over, they remain well for about a year or sometimes 1.5, and then they come back with the same things again, and you have to give another courses like 6 months. So is that experience in your case also that we need to repeat this kind of therapy again for these patients in your practice? Have you seen that?
Yes, that's a very much possibility, because we know that urticaria, whenever we tell the patient about it, whenever we offer Omalizumab also, we tell them we are not offering a cure, we are offering a control here. And they may still get episodes once they stop using it. So that's always a possibility. So here we are not replacing Omalizumab with other drugs. We are trying to reduce the severity because she's not controlled on routine antihistaminics, So with this, her dose of antihistaminics has come down, but she's still taking antihistaminics. So
yeah, I fully agree with you, because they are on every possible antihistaminic which is available over the pharmacy and still not doing good because they still keep itchy. So that is very true. And my question will be now to both Vinay as well as Pooja, that as Aditya has said that, the biosimilar versus the original one, he feels that it's not exactly the same, but maybe 80 to 90% same in our respiratory practice. What about in your derma practice? Is it same biosimilar versus Omalizumab, which was like Xolair?
I have given Xolair as well as biosimilar, and I don't see much difference. I think it's
So
doing
derma practice. Vinay, your comment?
As far as Xolair and its biosimilar is concerned, there is not much of a difference. But yes, there is a difference between a biosimilar and intended biocopy. Because in biosimilar, the cell line has to be the same. It is either same or has to be similar, not exactly the same copy. But intended copies are also there in the market, and they do not work at all. They are not efficient. They are efficient only to 60%. And as we were discussing about the anti-drug antibodies, for Xolair or for Omalizumab, the anti-drug antibodies which are developed are non-neutralizing. But if we are using intended biocopies, then there is a possibility of having
less amount of control.
Yes. Yeah. Which is there in other diseases. Like I said, I treat psoriasis, psoriatic arthritis, and rheumatoid arthritis and ankylosing spondylitis also. So in those cases, yes, we do get biosimilars which are not very effective as compared to the original innovator molecule, but biosimilars which are using the same cell lineage, they are very effective.
So my personal experience, I will just quote a word that those who are not paying from the pocket, Xolair is the best.
Correct.
Those who are paying for the pocket, whatever is costless.
Absolutely.
Very
Absolutely, sir. Absolutely. Those who are getting it funded by the government or some other agency, Xolair is the best.
So I think in today's seminar, we have learned not only the respiratory medicine, severe asthma, where we use Omalizumab, but also dermatitis, allergic dermatitis, as well as idiopathic or the food allergy, as well as urticaria as the other indications. And the only indication left to discuss was a chronic sinusitis with nasal polyposis, which is another on-label indication for using Omalizumab. So next time when we meet together, hope to see an ENT specialist also on board and have a case from his side also to discuss about the ENT usage and particularly the rhinosinusitis. But Aditya, just coming to you and Arun, that since this is an overlapping field where we also see these patients with the troublesome chronic sinusitis with nasal polyposis. So if I find in those cases a reason to use any of the biologic along with asthma, I'll be most happy because I know that they're going to be good at 2 points. But when they have only one disease, they don't have asthma, then I am little inhibited to use biologics considering the cost. What is your experience? And then quickly by Arun, right?
Sir, judging with the serum IgE level and the symptoms of the patient, if the IgE level is high, then there's a clear indication of putting him on Omalizumab. But if with only sinusitis patient is persisting, so we can try all the other things. If she's not responding, if he's not responding to the steroids and the sinusitis treatment, then we can go for Omalizumab. Why not, sir?
Arun, your comment.
Sir, I don't prescribe Omalizumab if the patient is having only sinusitis. I
Okay.
often see ENT physicians doing that. Even before a FES, they give the patient 300 milligram of Omalizumab.
That will be very unusual. They want to do FES first.
They want to do first. Everybody
That's
comes with a first
that is their
suggestion.
bread and butter. They would like to do FES first, and then because of the recurrence to come, they will use Omalizumab for that. So that's one thing. Yes, you are right that as a pulmonary physicians, we are not so happy to use it for
Yes, sir.
only chronic rhinosinusitis and nasal polyposis. However, if it is associated with asthma, then obviously it is one additional indication where you will be feeling happy to use it because you know that it is going to target the nasal cavities as well as severe asthma. So we are happy about that. So I think it was excellent cases, beautifully brought by everyone here.
One comment, comparing Bolstan and the Emzumab, now it is very clear for the younger people that we should use two different syringes. So one for loading, one for diluting. So that is the only difference I found. Earlier, we used to have the same syringe. We used to educate our younger people to say use two different needles to load. That is the only difference with Bolstan and Emzumab. They are having everything in a sealed packet so that you can understand what is required for what.
Right. So I think that brings us to this end of the program. We had lots of learnings today, lots of take-home messages along with it. And of course, the most important thing is, as far as this field of anti-IgE therapy is concerned, perhaps this is a molecule, Omalizumab, which has seen the maximum usage over the years, as well as the safety and the efficacy has been done in trials which are nearly going on to number would be somewhere around 100 plus clinical trials. So in comparison to all other biologics, this stands there is a biologic like Omalizumab which has stood the test of the time. And it still continues to be used, and with newer and newer indications being extended into it and getting on-label approvals. And the latest one is a chronic sinusitis with nasal polyposis. Obviously, the cost is the very important thing. I do remember that even in allergic rhinitis, it works very well. But who will spend the money on buying an Omalizumab for a treatment of allergic rhinitis when the intranasal corticosteroids will do equally effective and perhaps a much cheaper option which is available to us? Anyways, all this is going on, and there will be more such activities, and we will be learning from our other specialty colleagues, and we'll have a multidisciplinary discussions like this, which are going to be brighter and of great use to everyone. With that, I would like to close this session today, thanking my panelists, Dr. Vinay Singh, Dr. Pooja Agarwal, Aditya Chawla, and Dr. Arun, as well as the host, which is the CIPLA, for doing this program. Thank you very much, and let's see and hope to see again.
Thank
Thank you so much, sir. Thank you so
sir.
much.
Good night, sir. Thank you.
Good night.